in the interests of keeping to the schedule if we can. So it's a pleasure now to introduce Dr. Joost Kummeling. His talk is titled Mapping and Tackling the Development and Psychiatry in Kleefstra Syndrome. So welcome, Joost.
Well, hello, everyone. It's interesting to have this this conversation with you all digitally. I'm hoping that I can share the right screen. Let's see. And if everything is right, you can see my presentation right now. Is that correct? I think it's okay. Can you see my presentation?
Yes, we see it perfectly.
Okay.
Thank you.
I just wanted to know if you have the right screen, because I have two screens open and you never know what you're showing.
Perfect.
Anyway, of course, good morning, good afternoon, or good evening, depending on where you are. My name is Joost Kummeling. I am a medical doctor and PhD student. I'm working in the Radboud University Medical Center in Nijmegen, which is the place that Tjitske described. I work together with Professor Tjitske Kleefstra in my research regarding neurodevelopmental disorders, and specifically Kleefstra Syndrome. And at this point, I also want to thank all the wonderful people of IDefine who've made this possible, this whole conference, and that I've been given the opportunity, of course, to tell you something about my research. I will focus mainly on psychiatry in adults and adolescents with Kleefstra Syndrome, and it is called, which Maya Chopra just said, Mapping and Tackling the Disordered Brain in Kleefstra Syndrome. Okay. In a way, my study is a continuation of the work of Dr. Carlijn Vermeulen, who's a children's and youth psychiatrist here in the Netherlands. Unfortunately, I don't think she's attending right now, but I will be showing some of her work. Over the past few years, she has done quite thorough research on psychiatry in genetic disorders, and mainly in Kleefstra Syndrome. And what she found out is that the people who suffer from Kleefstra Syndrome often experience psychiatric problems, which can be quite challenging to diagnose and treat. And that's one of the topics that Dr. Sid mentioned. And he told you something about that as well, but I have to tell you beforehand that I can imagine this can be quite concerning to hear. But I have to tell you as well, we don't know everything about this yet, because research up until now has been on very small numbers. So we do not know exactly how often these problems occur, but it's nonetheless quite important to study. Anyway, one of these psychiatric problems, I'm using some PowerPoint slides of Dr. Carlijn Vermeulen with her consent, of course, can be depression, or how it's called in this slide, major depressive disorder. And important to note that there's people with an intellectual disability that often show different symptoms of depression compared to people without an intellectual disability. And for example, as it says here, let's see, I use my laser pointer. As it says here, often people with major depressive disorder do not have a typically sad mood, but a sort of irritable mood, or reduced sociability, and which is important to take note of. And second, as a repetition legitimizes, we have seen that people with Kleefstra Syndrome can experience psychotic symptoms or psychotic episodes, which often surface during puberty. And in this case, treatment of these symptoms with medication, and what Dr. Vermeulen also saw, especially with anti-psychotics like Olanzapine or Clozapine, seem to be quite essential for the well-being of the person experiencing the psychotic problems. And as one of the psychotic episodes can often lead to regression. And regression means that a person can really have a loss of functioning. So a decrease in daily skills. These can be all kinds of skills. So it can be loss of verbal functioning, verbal skills, can be a loss of social skills. I will give some concrete examples of that a bit later on. And furthermore, one of the things that Dr. Vermeulen also mentioned is that in her research is that there are often sleep problems, and these often occur with people with intellectual disability, but especially with people with Kleefstra syndrome, and you might even recognize that from your own child. And especially for these kind of problems, they can be quite difficult to experience because, as you can imagine, if one person of the family isn't sleeping, is awake all night, you can imagine that the rest of the house is also awake and cannot sleep as well. And those sleep problems can also have a negative effect on someone's well-being. As you can imagine, if I skip one night's sleep, I'm a different, I function differently the day after. And let's imagine if I skip one whole week of sleep, that I will be a completely different person. So that's one of the things Dr. Vermeulen saw, and she wants to see highlighted. So in summary, these psychiatric problems that may occur are often hard to diagnose as well, and hard to treat. So hard to diagnose because they look different, and hard to treat because we don't know that much of them. And well, this is the conclusion. Therefore, we found out that this is one of the things that we must study. So studies are in small patient groups are quite difficult to set up because it's quite rare. It's quite difficult to get any funding, to get the right amount of patients. But Professor Tjitske Kleefstra managed to get a research grant from ZonMW, that's mentioned over here, to conduct a patient study. And that's the study that I'm going to talk about most now. And it's a follow-up study of 4 years with multiple centers around the world. And it started in April 2019. So we're coming up to the almost 2 years now, and we're almost in the 3rd year. And beforehand, we thought, well, what do we want to accomplish with this study? These are our main study objectives. So we want to develop and implement intervention strategies for the Kleefstra syndrome in the case of psychiatric problems. And as secondary objectives, we want to develop a follow-up strategy for Kleefstra syndrome patients with special attention to the behavioral developmental changes, to understand the underlying causes of the regression observed in Kleefstra syndrome and the mechanism of Olanzapine, since Dr. Vermeulen saw that Olanzapine can have quite a positive effect on people with Kleefstra syndrome experiencing the regression. And because we don't really know what exactly underlies the regression period, we sort of hypothesize that there might be a sort of hormonal influence there because people around 15 can experience a lot of stress, and all kinds of hormonal changes in their body, so that might be extra vulnerable for regression. But we don't know that for sure. And the third objective is to prevent the general regression in patients with Kleefstra syndrome. And we thought about which patients should we include. Well, of course, we want to include people with official diagnosis of Kleefstra syndrome, with written informed consent, who actually agree to all the things of the study, or not even all the things, but yeah. And who are 12 years of age or older. We specifically focus on the group of 12 years of age or older because, well, we want to focus mainly on the regression side of the Kleefstra syndrome. And as I mentioned earlier, this mainly happens during puberty or after. And if you include people who are 11 years or younger, you don't really get that into your study. You don't really see that regression. This is to study all these aspects. We put forth a test battery which comprises of several questionnaires and several neuropsychological and psychiatric tests. I'm going to run you through this. And of course, this is to map all the different aspects of the Kleefstra syndrome. So for the clinicians, I've listed here below all the different tests that we are using. And to start off, I told before we want to have to map different aspects. So we want to, with the questionnaires, we ask questions about the communication skills of the participants. We ask questions about the daily living skills and sociability skills. I have a couple of examples. So these are standard questionnaires, and questions that are being asked are on the communication side. Does the person know the meaning of at least 10 words? Can the person indicate a preference if allowed to choose between two things? And on the daily living skills side, we ask, for example, is he or she able to eat with a spoon, or is he or she able to make his or her own bed? And of course, social skills, to give you two examples. Does she express two or more recognizable emotions, such as happiness, sadness, fear, or displeasure? Or can she keep a secret for at least one day? And all these three skills, like communication, daily living skills, and sociability skills, we all group together, and we've called adaptive functioning, which is a term widely used in research. Next to adaptive functioning, we also want to see if there are any sleep problems, if there are any problems with depression, and if there are any psychotic problems. This symbol here is meant to represent sort of schizophrenia, hallucinations. And on the neuropsychological / psychiatric tests, we want to do an assessment for autism. And we want to see how good someone's memory or learning is, and we want to see how good someone's visual spatial awareness is. So it's called visual motor integration. It's quite difficult words, but it actually means how does someone perceive something, and how and can somebody execute that. So what that means is that I will show the participants a diagram or a sort of a symbol, and they have to see that, they have to copy it on the same sheet, so I can see how well they do that. This is the timeline of the study, and what we do, I told you before, it's a follow-up study. So in year 0 at inclusion, we do the questionnaires, we do the testing of all kinds of the aspects, and then 1 year afterwards we do the same, and 1 year afterwards we do the same, etc. And then we go and see if there are any differences between those time points. So we can see, has somebody improved at some points in time with communication, or was there some other problem going on? And so we can really analyze somebody up close, how someone develops, and if someone develops psychotic problems or sleep problems or a regression. So at the moment, we're busy for almost 2 years now. We have some data, but we have some data, but I want to show you what can we expect from our experience, because the data that I have is not big enough to draw any big conclusions at this point. I have to say this is a rough estimation of what we expect to see from our experience. And from our experience, we estimate that sort of this might be maybe the natural course of the regression. And what we often see, as Dr. Vermeulen mentions in her work, is that sleep is often one of those things that people most often get problems with early on in the process. You see that a very rapid decline in quality of sleep, and afterwards you can see decline in the adaptive functioning, so the daily living skills, communication skills, and sociability skills. And after some time, you can see that, well, this is our estimation, that we've learned from our experience that there might be some sort of equilibrium, but that people do not really get back to their old level of adaptive functioning. So they actually effectively have lost they have lost skills over time, and this is called regression. And if you remember that I said that we want to prevent this general regression in patients, so we thought about, well, okay, how can we do that? So this is one of our expectations. If we see that there are problems arising, like sleep problems or decline in adaptive functioning, we know that we have to be on time. We have to treat those patients in time. But how do we treat them? That's the big question. We saw that that Olanzapine has quite a positive effect on these people. So the study that I'm conducting mainly focuses on Olanzapine. And our idea is, from our experience as well, is that if you use Olanzapine in time, you can see that there is that people will climb up after the whole psychotic episode. So people will their sleep will restore back to will restore, and they will improve with their adaptive functioning. It's difficult to say in what degrees people will recover, but at least we expect to have quite some improvement. So as you can see, there's a far less level of regression that people can experience. I imagine this can be quite alarming for you all to hear, but this is quite the main issue we're trying to tackle with this research, and it's quite relevant for us and for you, I imagine as well. For this study, we set up and we calculated that we need around 60 people to participate in order for our results to be reliable. And as Dr. Kleefstra mentioned, is that the Netherlands is a small country, so we do not expect to have many patients around here, but we hope at least to find around 40. Up until this date, I have included 31 patients for the study. And but we're getting there, but we're not there yet, and therefore we also have a collaboration with many people around the world to gather those 60 people. And of course, with your help, I hope to after this talk, I will hope to get some more people as well. So these are our current collaborations we're going on. Here's the Nijmegen, and we're Boston is over here, and we're closely collaborating with Boston Children's Hospital to set up a part of the study there as well, and they're quite far with that. And we're also collaborating with some people in Denmark, but mostly with people in Manchester, with the people in the Royal Children's Hospital over there. And we also working together with Baltimore and even Sydney. So it's a global effort. And we have received emails from around the globe asking, well, how can I contribute? Maybe you're asking yourself the same thing as well. And I can say you, well, as it says in the booklet that you received, we would gladly invite you to participate in the study. It's called here the Natural History Study, which is sort of is, but it's also very. We also want to focus on medication as well. And let's see, and maybe if you don't live close by, if you don't have the opportunity to go to one of those centers I just mentioned, so with Manchester and Boston and Baltimore sort of becoming the main other hubs for this study, there's also a second thing that you can do to help this part of the study, and which is the participating in the psychopharmaco study. It's a survey, and it's sort of addition to the study. It's a survey that I'm making, and I will send out quite shortly. It's in 7 parts. It's a survey where you can fill out general information, medication of your child, regression periods that have happened, sleep, and we will ask about comorbidities, which is a fancy word for other diseases, other problems that are occurring as well. And we ask for the references of the healthcare professionals that have assisted in the healthcare for the person you're caring for. And we also have some room for optional remarks. And in this case, I told you before that my research itself has sort of an age restriction because we want people age 12 or older, but for this survey, it doesn't really, we don't have that. It's still a work in progress. I'm working to get everything together. It's almost done, and in due time, I will make sure that everyone that's interested will have the opportunity to participate via some sort of link that you can use. To conclude my presentation, actually, I'm doing quite okay, maybe with time management, but I want to show you some of the results that we've been getting. So this is work by Lotte Bormans. She's a biology student here in Nijmegen. She worked as an intern for me, and she studied the location learning test. And it sort of works like this: that people with the participants get shown this sort of memory board with a couple of images of objects in them, and they get around 15 seconds to memorize where everything is. Then afterwards, there is a blank board put on top of that, and I hand them out cards with images, with the same images as they just saw, and they have to place them on the right spot. So they, if everything is well, they should have memorized where everything was, which is quite difficult. I've tried it on various people in the hospital, colleagues of mine, and they find it difficult as well. And you do this one time, but then you repeat this whole task. So again, you let them see the whole board, then you cover it up, and then you give them the cards. And what you can do, you can, every time you have to if you have to write down the placement error. So are the objects correctly placed or not? And then you can get these kind of results. So these are some of her results. Lotte Bormans only included 5 patients, since we have only 5 patients at the time she was doing her internship. The numbers are low, but therefore we have to take the findings with a grain of salt. What we can see is the following. There are 2 people, like patient number 3, participant and 2, who are clearly seem to be improving over time. So per trial, they seem to have less and less placement errors. But on the other hand, the 3 other people, as you can tell by their horizontal lines, have around the same amount of placement errors. So they do not seem to be learning. And you can calculate the learning index from this. I won't become too technical for you, but a learning index, if the score is 1, then you've memorized everything completely on the first try. And if you look at this table over here, you can see that the people who are learning, who are participant number 2 and 3, have a learning index of around 0.4, whereas the sort of the people who achieve these horizontal lines have far lower learning indexes. And we thought, well, maybe this is because it correlates with their adaptive functioning. So we compared their learning index with their adaptive functioning scores. And as you can see, the score of patient 3 is quite high. This is the so-called developmental age. So meaning this person functions on the level of someone who is 9 years old. And patient 2 functions on the level of roughly a 3-year-old. And you have to bear in mind here that all participants are 12 years or older. So interestingly, the developmental age is also quite high with person number 1, but doesn't really seem to learn from what you can see from the index and from the line which is over here. And I can tell you that this person was sort of struggling with concentration, and this may explain this result. So it seems as though the results of the participants here depend on developmental age, so that they are more capable of memorizing, of learning. But again, you have to take this with a grain of salt, and these are only 5 people, so it's difficult to draw real conclusions from this. I will analyze the rest of the people this spring. So these were 55 people. I have more than 30 people now, so it'll be a different task. And I will go through these slides a bit more faster. One of the work from Veerle Soeverein, who was also an intern from me. She showed that the developmental age that I mentioned earlier seemed to be different from the people in our group. So if we split the group up in females and males, we see that overall the females have a sort of a higher developmental age, so a higher level of functioning, of daily living skills, compared to the males of the group. And while their biological ages were the same, quite around the same. That's just some work I wanted to show you briefly, just to give an image of what I'm doing. And well, I want to show you this one. We also are busy with objective 2 to understand the underlying causes of the regression, and therefore we have the wonderful work of Neil Nadeef Kasseri, who will be showing neurons derived from the from stem cells of Kleefstra syndrome patients. To conclude, what key points of my presentation? So psychiatric problems can occur, but look different than most doctors are used to. So beware of that. And this study aims to set up an intervention strategy for these psychiatric problems. And in the case of psychosis, it is important to really try to treat in time. And especially I want to address the families here. Beware of the sleep disturbances and regression, as they can have quite a big impact on your life, and of course the life of your family member. And you can contribute to the study via the survey or by contacting the contact information that's in the booklet. And I want to stress as well that that parents can experience a lot of stress, and you're so busy with your family member that you might forget yourself. So don't forget yourself is what I want to say. And there are patient groups online, as you may already know, via IDefine, kleefstrasyndrome.org. There are many Facebook pages that you can go to maybe find support, to maybe exchange experiences as well. And I want to conclude with this slide. So to help, please, if you can, help us investigate the Kleefstra syndrome via this study. So if you have specific questions regarding participation, you can also mail me. As Jacqueline Drew has her email address below, but you can also contact me if you like. I'd like to thank everyone that has made this whole conference possible, the whole IDefine, and everyone that is participating, doing their best in working, doing research on the Kleefstra syndrome, and of course specifically Dr. Kleefstra. And also would like to thank these people who have designed some of the images I used in this slide. And of course, to really conclude, I would like to thank you all for participating and listening and looking at my presentation. So I think there's now some time for questions.
Thank you so much, Joost. And thank you everybody for your excellent questions and comments that are flowing in. I just want to assure you that we are monitoring them and we are curating them, and regression being a major concern for all of you will be discussed in more detail later in the conference. But for now, I'm just going to highlight a couple of questions, Joost, that have been asked that you might be able to answer fairly quickly. One is whether there could be a role for prophylactic Olanzapine to prevent regression, particularly in the older children with Kleefstra syndrome?
Oh, that's a very interesting question. I get it. Some people ask me. It has been asked me before, and it's very interesting to think about. But as Dr. Sid mentioned beforehand, he mentioned mentioned Olanzapine as well. It is not a really how do you say it? This drug can have quite a big impact on the well-being of the patient as well, as every drug has. but olanzapine has good effects, but also side effects. So you have to keep that in mind as well. And there are many side effects that can occur. So you have to really monitor those things. And what we really say is, if there are no problems going on, you don't really have the urgency to already start olanzapine, since it can have quite some severe side effects as well. So it's not a wonder drug, so to say.
Thank you. And a second question that I think a lot of our families are wondering about is whether, are there any patterns in individuals that could predispose them or maybe give them some vulnerability to developing regression? For example, if they have a particular level of ID, if they have certain behavioural problems, is there anything from your preliminary data or even just what you're seeing clinically that would highlight some patients as being more vulnerable for this complication?
Interesting question as well. Of course, it's difficult to draw any hard conclusions from everything that I've done up until now, because I haven't really I didn't dive really deep into my data just yet. I'm just collecting everything right now, and analyzing will be a bit later. But from my experience, I do not really recognize that there are specific things that really jump out as being the sort of aspects of those people will make them especially vulnerable. I've seen that people with maybe what I can say people with a relatively low level of adaptive functioning might not experience as a severe regression period. But I'm not really, that's not really evidence-based. It's more sort of, so to speak, more of anecdotal thing. So that's one of the things that I've sort of seen, but not really. You have to take this with a grain of salt as well. Yeah.
Thank you very much, Joost, and I'll ask you to continue looking through the Q&A for questions that you can answer. And in the meantime, we'll move on to our next speaker.